Hello, and welcome to another episode of the Healthcare STARcast. And we haven't actually spoken specifically about stars, and we have two stars industry leaders along with me here, Mark, Ryan, and Neetu. And just to put things in context for the audience today, just in the previous episode, we talked a lot about the Medicare Advantage and Medicaid industry, what is coming in 2026. What are the things that plans need to be prepared at a high level with John Gorman? Today, we're going to jump in, double click on not only what plans and providers and the ecosystem needs to be successful overall, also specifically on the star side. We're going to talk data, stars preview 2, what we're seeing, etc. Welcome, Neetu and Mark.
Thank you.
Thanks very much.
Excellent. Mark, why don't we start with an introduction about you? You have a very unique and interesting story. So tell us about you and your background to the audience. You don't need a lot of introduction to the industry, but at the same time, for my audience, it'll be great to hear your journey.
Sure, great. Thanks so much. So just from the healthcare perspective, I started out in government in Connecticut. I was sort of the healthcare policy person and ended up becoming the budget director and management secretary. So really sort of honed all my chops on all sorts of healthcare issues, Medicare, Medicaid, and all of the waivers and things that you really need to run a state. So that was a great job. Loved it very much. I went on after that to go into health plans for about a decade or so. I've been a very large ones, small ones. I've started up some Medicare and Medicaid plans along the way and some special needs plans. After that, I teamed up with two IT folks at very senior levels in health plans to create MHK or MedHawk. And so we had a great journey there. The company was sold to Hearst. I stayed on with Hearst for a number of years. Hearst is a tremendous company and they continue to invest in technology. But once I left MHK, I teamed up with Neetu. It was a bit of serendipity. And Neetu will probably tell you a little more about Lilac Software and why it exists. But I'm really delighted to be with Neetu and our other co-founder, Alex Schaefer, on this new journey trying to help health plans.
Excellent. Thank you, Mark. And you two will kind of cross paths each other in the health plan side a little bit. You were the CTO for Oscar Health Plans in the past, done several roles in technology. Love to hear your story as well.
Yeah, thank you for having me, Subbu. It's really great to be here. My background is almost all building tech for enterprises. I spent a lot of time outside of healthcare. Compared to you and Mark, I'm a newbie. I walked into healthcare in 2019. It was very intentional. I was unwell. My mother was unwell, and we're both fine now. But it was the first time experiencing healthcare system itself at like such a deep level, and it was very much intentionally walking into healthcare with my bag of tricks and my experiences and skills and see what I could make better. I was at Oscar Health for 3.5 years. It was an amazing journey. It was an extreme learning opportunity for all things that are health plans, how they work, what tech you can actually bring to the equation to solve which problems are tech problems and which problems are not tech problems. Oscar, as you know, was one of the initial health plan that built everything that they use from scratch, which was quite amazing. And it's not because we wanted to, it's because we had no choice. So it was great building everything from member engagement tools to broker tools, MCM, prior auth, even our own enrollment billing and claims processing system, which was the last thing. And it was quite an amazing journey. And at some point, we were also trying to package up and sell the Oscar tech stack to other health plans. And during that journey, kind of got really exposed to the fact how the data is extremely fragmented in most health plans. And that fragmented data leads to lots of governance issues, quality issues that directly impact member care, provider relationships, value-based care. It seemed like the root cause of so many problems. Very, very much got inspired to build Lilac to support removing the data lags, to make data that is good and usable and robust available to all of the plan business users. And we're starting with STARS. And yeah, it was definitely serendipity that brought Mark and I together. Somebody we both knew said, "You are both talking to me about the same thing. You should go just talk to each other instead."
Excellent.
So that was
Two
great.
stars coming together right there.
It was meant to be. It was meant to be. Yeah.
I can't wait to dive in even more, Neetu, especially for the audience, sharing your perspectives, especially on the data lag side and AI and all that, how those are interconnected on stars. So before we go in, I will actually start with Mark from an overall industry perspective. Mark, right now, we are sitting on September 10th. We are recording this conversation. Last night, the plan preview to cut points were released. Just been a day, and we're all looking at the cut point data, and the health plans are looking at these, have the STARS plan preview information, risk adjustment audits. RADV is going on, and CMS is still trying to get all the coders that they want to recruit for RADV, and sequestration. That's something that we talked about in the last episode, about 4% impact for Medicare Advantage plans. So many things going on, including the big, beautiful bill impacts. So would love your thoughts on the external forces impacting the community and the members and the patients on what is going on. Where do we go from here?
Sure, great. And I think, a little bit of a clip from John Gorman's appearance with you out there. And I never intend to say I'm as good as John Gorman or be able to prognosticate the way he does. He's a legend. So, and I've known him over the years. But just in a general sense, I really think that there are some external and internal forces that came together to create this health plan crisis, right? The external forces are aging, it's the return of inflation, and it's a lot of issues with rising utilization coming out of COVID, but utilization that is there as well that is hard to explain. We could be in a new era of utilization, and it's driven a lot by drug introductions and things like that. So good and bad, right? We want the best drugs out there to cure disease, but we're also seeing major increases in costs and price because of it. So I believe we're going to be on that journey for some time. I know a lot of actuaries and economists are saying we're going to have a spike and it's going to come down a bit. I'm not so sure about that. I think we're in for a little longer term look at heavy utilization as well as pretty high price. I think the biggest problem is in the employer world. We are looking at 9% trends before adjustments in benefits and things like that. And we've seen that for a couple years now, and it's projected to go into 26. That's a huge problem for both being uninsured, because people will drop off the rolls, as well as being underinsured. And I'm actually worried more about the issue of underinsured, because as price and utilization goes up, employers try to safeguard their employees, but it doesn't always work, right? So that's a big problem. Internally, I'm a health plan friend, but I will say that I think health plans had huge strategic errors in how they managed their health plans. They sort of rested on their laurels and had a lot of good things coming in with COVID, and they sort of lost track, right? I can't blame them totally because it was a pandemic, but at the same time, I think they got cocky, they got overzealous, they overexpanded, and those external forces and those internal lack of discipline has really created the problems we're seeing today. I think the one big beautiful bill complicates efforts, right? So many of these big guys and some of the regional plans are now trying to get back to margin, so to speak, and to meet investor expectations. And I think they're making progress there, right? We see that with some of the reports from CVS, Aetna, and Humana. They're making progress. HIT came later, but I fully believe that they're going to sort of come back as well, Centene as well, and big plans like that. But no question, the one big beautiful bill with 15 million potentially or more fewer people on the rolls and rising risk both in Medicaid and in the exchanges. And then, of course, some of the changes on MA. We're seeing a very large rate increase in MA, 5% plus for 26, but we're still seeing trends at 9%. So all of that, along with the RADV announcement, and probably I would predict stricter prior auth in MA, is going to complicate recovery. So it's going to take some more years than we see. And that has massive impact, I think, on employers as well as membership across the line of businesses.
Awesome. Well, painted, Mark. I think you covered all important areas there. I'm sure this is an ongoing conversation until the end of the year, early next year on these market dynamics, but super helpful. I'm going to transition to stars a bit. As we're recording this conversation right after Plan Preview 2 is released. There are cut points that are gotten harder that we expected, also because, all the health plans of performing better. That is sort of the theme that we expect in general. But I'll start with you, Neetu, from a stars landscape perspective, from the data angle, from the overall landscape. What are you seeing, right now, especially September? This is a time for many sprints and many things in the industry, in the stars world. So what are you seeing that are going on?
Yeah, I stars is very much, it's very much an exercise in taking care of people. That's taking care of people that are your members, but to know exactly how to take care of them and exactly what to do, you kind of have to know what the current state is. And we definitely obsess about how close am I to a cut point, how well am I doing on a measure, but it really is about like knowing where a person is and what help they need and how do you encourage them to refill a prescription or get a test. And that, I think, is where most plans struggle quite a bit. Like the provider chase lists that go out of providers, by the time they get to providers, they're fairly innocuous, right? Like those lists are very out of date. And that data lag in terms of knowing what needs to happen and when it actually starts to happen is, I think, the cause of a lot of challenge. A lot of plans, I think, have relied quite a bit on data that may be coming out of Acumen or data that may be coming out of their HEDIS engines to drive the chase lists. And there are built-in delays in all of those, right? Like Acumen report doesn't even show up for several months in the beginning of the year. And if you're talking about poly-ACH or COB measures, your ceiling is already lower by the time you actually get your first report. So those are some of the things that we're seeing. And I think as we enter this last 3.5, 4 months of the year, there is a lot of time still for plans to make a difference. And in fact, we at Lilac just did a podcast that is freely available to everyone to watch, and we can maybe like share the link. There are several things plans can do right now, right? Like we can actually start validating data across like what's happening with the measures and start fixing it. That's star points. We can start using real-time ADT feeds to figure out how to impact, transition care or PCR measures. That can start right now. We can start using agentic AI to making phone calls to remind people to pick up prescriptions or to just figure out what they need help with. We can start that right now. And yeah, I know we're in the third quarter and it's post, fourth quarter, closing out third quarter, heading into fourth quarter, but that's still like a third or a quarter of the whole year left. There's still a lot of time to make a difference. And there's even more time to make a difference for CAPS and HOS. So things aren't lost. There is data challenges, lags are there, but we can actually like close those lags. That is something tech can help you with directly and like drive the outcomes for the members and the plans.
Yeah.
There's opportunity right now. It does need commitment.
Absolutely, Neetu. I think you hit the nail on the head in terms of also optimistic here, right? We have so much opportunities left.
There is.
I think one of the things that you talked about in terms of data delays, because of data delays, by the time you intervene, it's too late. It's too late for members. So there are things that you can do here. Mark, would love your perspective along with Neetu here, right? The historical 3-year performance in terms of overall stores is going down year over year. But at the same time, there are winners in this, right? There are totally winners in this. I'll tell you, my previous health plan, we increased while the overall performance decreased. Clients who actually are feeling really good, this year, of clients who are not feeling good this year. So it's a mixed bag of, things that you probably also see. But in terms of outside of the data component that Neetu talked about, Mark, what are your thoughts right now outside of just kind of working on the interventions on the star side? What do you recommend holistically right? For plans to not only finish the year strong, but also prepare for early next year, caps and HOS, cost of care that you talked about. So would love your perspective there.
Yeah, sure. Great. Absolutely, Subbu. You're absolutely right. 2022 stars peaked. We've seen 3 years of drops. I think we'll probably in October see a slight uptick and move back up. We're already hearing United say that they are moving up in a investor disclosure. And there's some intimation that some of the other big guys are doing that as well. So we'll probably move up, but we'll still be relatively low compared to where we've been over the last 10 years, which is sort of troubling. And it ties back to some of the complexity and data issues that Neetu talked about. I think diligence would be job one here coming into the last quarter or so. And I think people really have to reflect on where they really are on a given measure. Many people have hopes and dreams and they rely on special initiatives to get there. Sometimes they work, sometimes they don't. But hopes and dreams is not sustainable. You really got to sit there and say, am I close to where I think the cut point is? Cut point prediction is hard, but you can pretty much tell with optimistic and pessimistic and forecast scenarios where you're going to be. So what are the 4 or 5 measures that you can really impact in the last quarter, and driving it with incentives in close coordination with providers, I think is essential. And that really is what I think the secret to a lot of these high performing plans are. They're constantly knowing where they are, how they can improve, and they work with their providers very closely. I think periodic special initiatives with different tech vendors and things like that make some sense, for example, with colorectal screening and things like that, and BCS perhaps. But there's no substitute on an ongoing basis to really understand where you are and be very diligent about it. I would also tell you that I think many plans miss the closeout period. So there's a closeout period in roughly the first half of the following year, the measure year. And too few people are working both years in concert. They're not working the year that just ended, and they're not working the year that is now started. You got to work both years. Pharmacy measures can be increased in that 6-month period until the finalization roughly of PDEs and things like that. Challenging CMS on some of what you see in all of your data is important in that 6-month period. And then even plan preview diligence is key, right? Too many people are not really pushing back on the findings of CMS, and too many people are not, too few people are appealing, right? In our clients, we have had some notable successes aiding them in pushing call center initial findings, appeals, CTM, and things like that. So don't be afraid. We know it's hard to sort of bite the hand that's feeding you, but sometimes you got to do that. And 100%. CMS is pretty professional. And if you build a good case and you're diligent about it, and the earlier you mention it, the better. You can't tell them in Plan Preview 2, I think there's a problem, Houston. You got to do it prior to Plan Preview 1 at the latest in Plan Preview 1.
Well said, Mark. I think one of the things, Plan Preview 2, especially with all the things that happened with Elevance missing small percentage points on 4-star as an example, right? There are a few others. But Plan Preview 2 right now, the whole industry is trying to appeal every measure as much as possible, right? But at the same time, thinking about the following year, working both ways and challenging ahead of time. You're right. CMS is very professional about it. It's just data-oriented approach. But at the same time, with all these being said, there are different kinds of maturity across different health plans, right? And then also providers. One of the biggest things is the source of truth of data, right? I think something need to hit on, right? There are plans who are doing multiple spreadsheets and different tools, right? There are plans who have a consolidated EDW, who are working on not only the measures set from HEDIS, pharmacy, caps, etc. That's very few percentage of plans, in my opinion, based on experience. But Neetu, you and Mark and the team built an incredible set of services and product within Lilac, but at the same time, your approach is also slightly different than many of the competitors out there. So Neetu, if you can just talk about the consolidated approach. You also mentioned agentic AI, which we'll touch on a little bit later. What do you see as a flexible approach that Lilac does in partnership with health plans?
Yeah, thank you. So we, Lilac, think of the stars and quality effort that are driven as a pretty joint sort of venture, right? So it's a pretty joint sort of venture, and we're really focused on making sure that we're driving the right things or helping the plans drive the right things at the right time. And that all starts with consolidated good data to start with. So our platform is able to consume source data, like things, either what you currently send your HEDIS vendor, we can consume all of that. But the important part about our platform is the fact that we don't stop just at HEDIS measures. We're a HEDIS certified engine, we're an NCQA certified HEDIS engine, we're a PQA licensed drug engine. We have built all of the operational and the member sat measures. We've also built all of the star calculations. And as you probably are very aware right now, so for all example, like that is like basically recalculating all of the right measures with additional like constraints around which population you run them in, and then adding 3 more cut points, also called tertiles, right? So it is a very complicated set of calculations. And what we find is plans are currently doing they're doing some of these things or all of these things, but they're doing them in very fragmented ways. There's a group that may be doing just 1 or 2 of these things. There's maybe a group that's like figuring out what the right cut points should be. And what we've done with the Lilac platform is bring everything together in one nice, easy to use app so that star leaders and everybody that they work with can just get started. Our implementation timelines are extremely short. We are taking care of all of the heavy lifting behind the scenes of consolidating the data, running the measures, generating very timely results. So we're an analytics engine, we're a stars engine, we're a PQA engine, we're a star forecast. We do forecast of cut points, we'll do roll-ups, we'll do all of those things. So you can just get started with taking care of members. And within a couple of weeks of actually like signing contracts, people are starting to see value out of it. And we can also do it for like pretty standard, like dedicated plans that are very delegated. You can do it per measure. We can do it per provider. We can provide a group. We can do it, different groups of measures. Like there are many ways to cut and slice this data. So approach is extremely comprehensive. And what we're finding quite a bit now, especially after the big, beautiful bill, is these insights and reports are really hard to get to before. That took months, if not longer. Now people are getting them within days. And now what they're actually looking at is, okay, great. Now I have my drug chase list or med adherence chase list every day. As in somebody filed a claim yesterday, I know now today if they should be in the chase list or not. How do I actually deal with this like available opportunity to go close these interventions? And that's where like AI and agentic and voice agents come into play for us, where you don't always need a pharmacist to call Neetu and remind her to take, go get her losartan prescription. Right? Like you can have a voice agent call and do that. We're starting to do that not just with med adherence measures, but we're also starting to do that with some of the health risk assessments as well. As in, there are a lot of assessments that need to happen, especially for like DSNP plans, and those are all things that we can help with using voice agents to do, expanding the scope, expanding the reach, and doing it in a very cost-effective manner at that point. So starting from core data, we can run, prospective and realistic on near real-time measures, near real-time chase lists, and then tag on to that actually closing gaps.
Awesome, Neetu. I think I'm going to touch on a little bit more on the agentic AI side a little bit later, but I think you gave a good full overview, right, of your solution. But I think speaking of near real-time data, the biggest 2 gaps I see often in terms of data lags, dimensions. One is pharmacy. The next is transition in care. always a challenge. It's a CMS has beefed up this measure based on standards. It's going to be even more critical, not only from a star perspective, right? Mark, we talked about how this is highly impactful from a cost of care perspective. That's why it's a measure. It's a transition of care. Period. Not many people in the industry understand the implication. They just think that it's a quality function. It's a really, holistic measure. So let's talk about the drug landscape a little bit, right? The costs are spiking. You all obviously we saw in the plan preview 2 data, everybody's, except for one measure, every measure has actually the cut points have increased, and mostly reasons being, plans are getting better. And I can see, if we are in CMS's in the shoes, some of these, they will move the cut points, once like some of the performance gets higher and higher, right? And for a small, medium size population, Part D and pharmacy measures are really tough because you have small denominators to play with. Unlike Take United, as an example, you have high denominators and even few members here and there. It may not matter, right? They could even get to a 4 or 5 there. So, Mark, what's important from your perspective on the Part D side, connecting back why, what can we do creatively to handle the data lag issues right now?
Absolutely. Yeah, so Subbu, you're absolutely right. I think we saw a little good news in the cut points. We'll know really what happened, in October, but things seem to be improving a little bit, right? But it's also true that if you look at 25 results, these measures scored in that high 2s or low 3s, right, on average. And that sort of shows the overall performance level of drug measures has been historically well below those clinical measures. And when you think about, I always use the word roughly a third. It changes, year by year with weighting. But if about a third of your score, your overall score, is tied to Part D measures overall, that is one very big contributor to why 4-star and greater has dropped and not increased, right? So you got to do well on the Part C side, it's 2/3. But on the same side, if you don't do well on the 1/3, you're not going to get there either. And Part D and drug measures specifically have been a big problem. I really do look at it sort of in 2 ways. One, I look at it in the data lag. Neetu have talked a little bit about data lags there. The greatest data lag, if you're not using a vendor, or if your PBM, and not all of them have it, if your PBM does not help you close that gap, you literally are relying just on the Acumen data that comes through. Now, the first Acumen report every year comes out 120 days later, right, in April. And so essentially what you've done, if you're not doing it differently, you have ceded about a third of the year to, I'm just not going to work it, right?
Yep.
We haven't done anything. So literally you only have 2/3 of the year to really work it well. And even if you're still using Acumen, there's a data lag there that keeps going month after month after month. And so you're in a really bad place. And many plans that are solely reliant on Acumen are scoring 1s and 2s on drugs because the data lag is just so much. On med adherence, if you lose a couple of weeks of fills, you very much are not going to be at 80% compliancy, right? So if you have somebody that doesn't have good adherence in those first 4 months, you're already in trouble, right? And again, as you point out, the denominators can be small. And so if you lose enough of them right away, you just can't score high on the measure. So it's really important. I would always say, look at Lilac. We have an engine that can do real-time stuff, and we can tell you on any given day who hasn't filled a script, who's overdue, and how they look. And you can really engage with your provider that way. But at the very least, you got to move from Acumen to either an internal way or with your PBM, a way to restrict how long that gap is, right? There's proxying going on, but you can't just wait for that Acumen report because there are ways that you can even build reports internally to at least target who's not adherent and who's in your numerator denominator, right? That's easy enough to do. And so I would really encourage plans to deep dive on what they can do immediately on drug measures. And I will also tell you there's 3 different types of drug measures now, right? You got adherence, which has one type of approach. You have the statins, and very surprisingly, it's an easier measure theoretically to hit, but it performs low as well. I take SPC, the HEDIS measure for cardiovascular disease. Many plans are not familiar, and many providers are not familiar with the requirement to have a moderate or high statin dosage, right? And so educating people on that is key. Documenting intolerance, which is now allowed in both measures now, is important. So those are kind of strategies on statins. It's very much a provider intervention as opposed to maybe more of a unmet here. The COB and the poly-ACH, if you go 1 month and somebody's non-compliant, you're in that negative numerator, so to speak. You got to have a long-term strategy of risk assessing your members on those 3 measures. It's a long-term strategy.
It's long-term, yeah. Yeah, I think you hit the nail on the head with 2 things, right? The poly-COP and the adherence measures and statin measures. Many of these, if folks are listening to this at this time, you cannot impact the members who have not been impactable anymore, right? So key thing that it's a STARS 101 thing, right? You cannot impact what you cannot impact. So it is back to what Mark and Neetu talked about. It is a 2-year process. You're working on whatever you can act right now before the end of the year, correcting the PDs, etc. Mark, you talked about that's an opportunity, until July. Start now for 2026. Look at all the members who actually are going to likely be there, even if it's not going to be likely be there. Just look at them. I think a platform, a holistic platform like Neetu, you talked about approach, would go a long way. I remember using just Acumen data back in the day. It is, yeah. And then it was like, why am I getting 3 stars all the time? So just those few members.
You're doing everything you can, and that's the ceiling.
Yeah.
And Subbu, we mentioned earlier the reconciliation concept. We are finding that CMS does not always recognize, as we said, these exclusions or scripts and things like that. You can get your handful of members to get to the next star if you have a diligent closeout and monitoring process and tell CMS you think that they missed an exclusion for hospice or an ESRD exclusion. There are many different ways that you can, post the close of the year, get to higher ratings by getting a handful of people in the right place, either excluded or in the numerator.
Yeah. And the other thing that we're finding is people have been working very hard to address the list of gaps that are identified. With the tech and AI and machine learning where it is right now, you don't have to kind of wait. You can forecast. You can forecast and actually start closing gaps even before they happen, or you can avoid having gaps. You can figure out what is the right way to interact with the member. Maybe I would like a 90-day prescription just mailed to me versus, going to, or maybe Mark would always like to go to the pharmacy or talk to the pharmacist, all of that, all of those pieces, like the propensity for somebody to close a gap, to have a gap, and to, in fact, the right way to fill that gap. All of those things are way more accessible today with tech, assuming you have the data in the right shape and form.
It all starts there.
It all starts there.
Oh, sorry, Sue.
Please go ahead, Mark.
I just one thing, because it triggered in my mind with that dialogue. EHO for all.
Oh my God.
Actually now creates, and we could do a whole episode on this, right?
Yeah. Yes.
But it now creates a whole different paradigm, right? Because historically, not that plans were trying not to serve everybody, but the STAR system encouraged plans to look at the people with the greatest propensity to close any given gap, right? So people said, wow, these people were compliant last year. Let me go after them, and that's going to help drive my score. But EHO for all, taking the place of reward, means you really have to look at your barrier people and how do you solve it? How do you get them to compliance, as well as that greater propensity population? I actually think that's a good thing.
That's a good thing.
Because we need health equity and we need everybody to perform well, right? And I
Yeah.
know that's a controversial thing in some circles, but that's the right thing to do. But plans really have to rethink the strategy. And that's where AI helps, because AI can help you understand what barriers are out there and maybe a path to get somebody to compliant, along with lifting the burden of getting the high propensity people compliant.
Yeah, good point, Mark. So speaking of AI, I think if some of my audience and our audiences who are skeptical about it, so let's peel this a little bit, right? Because there are different aspects of AI, right? So I will start with you here, right? It's controversial, especially in the healthcare environment, right? So there was a recent study which would put it out there around AI adaptability by health systems. It is still a conversation, right? I think you talked about some use cases earlier about, hey, agentic AI to kind of just do a call to member, etc. But we are talking about in the stars world, people who are dual SNP, people who are really chronic, some people who are friends of mine and others who are actually skeptical in picking any kind of calls, right? So peel us through the onion a little bit here. So when you mention agentic AI and process automation, machine learning, etc., give us some examples on what
Yeah.
you're envisioning.
Yeah. I think it is worthwhile to actually listen to all the voices, and especially the skeptical ones, right? There's always a bit of truth in caution. And to start with, I think there are different places AI and agents and co-pilots can help. And before I list out the places, let's set the ground rules of what I mean by agents and what I mean by co-pilot and what I mean by just straight up machine learning. So there's a lot of AI washing happening in the industry. So let's start with machine learning is basically recognizing patterns in past data. So using history to guess and forecast and correlate what might happen in the future. You are never going to be 100%, but even if you're 90% in some places, it is worth it, assuming it's the right use case. The 90% validation to decide to send Neetu to the emergency room is probably not a good idea, but 90% validation to guess that Neetu needs transportation to get to her, pick up her medications, probably a good idea. So machine learning's all about finding patterns and matching and forecasting based on that. That I think including the health plan world has been using for a long time.
For a long time.
For a long time.
And big data, predictive analytics, machine learning.
Exactly.
All like the same
Exactly.
concept.
So that we've been using for a long time. Now let's talk about agents. Agents are really sophisticated technology that can make a plan to do something and then go do it. What it makes a plan to do and what it does is something that we should make sure there's human validation around it. An example of this is the voice agents. That is just one sort of example. Those are voice agents that can do text to speech and have a conversation, understand the things that you're saying, respond accordingly, have some guardrails around it. So we've played around with voice agents, and we've played around with voice agents for things like medication adherence reminders, for encouraging people to take their HRA, directing them to a website, doing a warm transfer to the call center, and at times even doing the HRAs, right? And works in some places, does not work with everyone because nothing works with everyone. Now, but I think the hidden layer in the middle is where there's a lot of opportunity. It's all about using agents to actually make the job of the humans easier. So think about literally every team, every care management team, and how much pre-work they have to do to ensure all of the data they need for making a certain phone call is there. Are they looking in their care management area? Are they looking for medical records? Are they looking at their claims data? Are they looking at what the phone numbers are for the members of the providers or the pharmacy? Are they looking at what was the last 5 conversations? These are all things an agent that is focused at gathering and sifting and summarizing data can do and present to the person that is actually making the phone call and doing, so they can be assistants. They don't have to do the work, right? So they can be assistants that do all of this like rote behind the scenes data gathering gopher sort of work and actually bring it forward for a person to actually make a decision. I don't think we're currently at a spot where agents should, like a voice agent or any agent should like independently make a clinical decision. It'll be a long time before I feel comfortable about that, even for my own self. But I feel very comfortable about letting an agent loose using an MCP server to go actually get all of the data and then letting a pharmacist or a nurse make the phone call, but aiding them with all of the information that they need behind the scenes available. So those are the two areas that we're focused on. There are some like low lift administrative sort of conversations that are low risk that I think are, and what we've heard plans tell us is like, oh, that's the sort of phone call for reminding people to pick up prescriptions that we don't even do because they are low risk and
Relying on
we don't
people.
have enough resources when you don't have enough time. So I think there is a wide swath of low risk activity that are not clinical that can be taken over by agents. And it does a couple of things. One, it lets you do those things at low cost, but it expands your reach. It's like when you could only call a portion of your population, but now you can try to reach all of them. But you can, like, even for HRA, an agent can make 10 phone calls. They don't have to stop at 3, they can try 10, they can try at different times. They can, try all the people in the population. These are all options that I think like AI makes it possible for us to do that, it changed what is possible right now.
Yeah. And thank you for clarifying and, giving that full clarity, right? On each of those, what does that mean? Right? So I think there are guardrails around this. Even if there's a small use case, everything starts with the right data. Even if there's a technology that you can actually outreach, right? Technology exists, but at the same time, if you're, doing the right phone call, it has to be to the right person who has the right gap. So it's connected to the data and analytics, part of it. And there is guardrails from a regulatory perspective, right?
Yes.
So I think as an industry, we're still trying to figure this out. I mean, Mark, we have CMS and also CHI, an independent organization looking at overall health AI regulation in general. What do you see, Mark, from a regulatory perspective, the use of agentic AI? Especially the agentic, AI component is the most scarier part in a way, right? The machine learning and so et cetera need to clearly articulate it. That's, people mix machine learning and, the agentic, component of it. What do you see, Mark? What do this is an evolving conversation. Things may change really fast here, but at the same time, if it's rightly regulated, especially in our industry, this could go a long way in terms of really enabling the right patient care.
Absolutely. Yeah. So I think of it, having been in government in two ways. There are folks out there that are talking about the evil of AI, and we need vigorous regulation over it. It's a knee-jerk reaction that often happens from some folks. And they sort of say big bad plans will co-opt AI and make things worse, right? That's sort of what they're saying. I think that's nonsense. Although at the same time, we've theoretically heard some case studies about plans using AI, for fairly nefarious things like claims denials and things like that. But anyway, that's one camp out there. I think there's another camp out there that wants a sort of free market hands-off approach. Don't regulate it at all, right? Go ahead, let them do what they want. We have to foster the use of AI. So any kind of regulation is bad. I am a little more aligned with that side of things, but I also think no regulation at all is a problem, right? There could be inappropriate use, and we have to regulate that and do some things there. So I really am fascinated by what I call an emerging, what we call risk-based approach to AI regulation. And this really applies not only for healthcare, but really across the board, right? And basically what you're adopting are the basic principles of the rules you would follow. Some of them are more requirements, while others are suggestions, but nonetheless, you have these basic principles, so-called guardrails around how you use that. Because we're in an emerging world, we don't really know yet what AI will or will not do, right? There could be bad things emerging. There could be very good things emerging. So have those guardrails, have those basic principles and maybe some requirements that are flexible and allow, plans in this case to move forward and allow AI strategists to sort of come up with evolution of AI. And over time, you evaluate those basic principles and guardrails so that you can really take in the pros and the cons. But if you have very aggressive regulation now, you probably will poison AI development in a very, very bad way. And I do feel like basic principles and guardrails are important. And I think that's where we're going, but you never know in politics, right? Politics so often responds to the headlines of the day. And so we have to guard against very, very vigorous regulation that is not really based in fact at all, really. And that often happens, unfortunately.
Great perspective, Mark, and around the AI piece. This is an ongoing conversation for sure. Speaking of headlines, we will certainly be seeing some headlines in October after the STARS release is done. I'm sure we will have more to talk about in terms of data, what else, that's in the horizon, and digging a little bit more deeper there, especially not only looking at the ratings, but also like what plans can do moving forward. In the meanwhile, folks, check out Lilac Software, and they're doing some cool stuff. You and Mark, this has just been a thought-provoking conversation covering from politics, AI, more importantly, STARS, pharmacy. Thank you for being on the podcast.
Thanks so much, Subbu.